Welcome to the Hooked on Health podcast. I am your host, Dr. Sean Lordan, physical therapist and owner of Concierge PT in Sutton and Shrewsbury, Massachusetts. And today we've got a distinguished guest, Dr. Alexios Carayannopoulos. Did I butcher that, or did I get pretty close?
Carayannopoulos, pretty good.
Carayannopoulos, nice and Greek. So, Alexios, just I'd love for you to introduce yourself and just kind of talk about your path to where you are today and how you got into pain medicine and surgery.
Sean, thanks for including me. So I'm Alexios Carayannopoulos. I am a physical medicine and rehabilitation specialist and a subspecialist in interventional spine and pain management. I am currently the chief of the Department of Physical Medicine and Rehab at Rhode Island Hospital, Newport Hospital, and throughout the lifespan system, which is in Providence, Rhode Island, and throughout the state. I've been here for 7 years, and I'm an academic physician affiliated with Brown. I'm an associate professor there, and I do a lot of research.
Excellent. So let's just dive right in. So let's just talk about your training and sort of what got you into, why did you want to go down the path of physical medicine and rehab?
Great question. So I was in the military for many years, and I got introduced to physical medicine, or PM&R, when I myself got injured. I was in a very active position in the submarine world, in the diving world, and function was key for my participation in team-based strategies and events, and my ability was impaired by a musculoskeletal injury. And I realized that I was a member of the team, and my continued ability to function had impact on the entire team, the entire mission. And I was personally introduced to a physiatrist at the Landstuhl Medical Center in Germany. I was stationed overseas, and they really helped me to understand what the specialty is and how what the uniqueness of the specialty is, and really dealing with comprehensiveness of what a patient might be dealing with. And it really looks at patients from a biopsychosocial approach, meaning all the aspects that deal with medical illness or physical illness need to be considered, not just, say, a lab work that's off or a specific injury such as a fracture. So it's a very comprehensive approach. And it resonated with me because being in the military and being in the teams out in the field, it really matters that everybody is coordinated together. And that was the first segue into me understanding this was a very unique specialty.
Yeah, I think that's great. And do you feel like the DO program, because you're DO versus MD, do you feel like that kind of that helped? That's more of like from what I understand, just from just a general from the PT world.
Yeah, DO another great question.
And do like the manips and things like that.
So as you know, there are two types of physicians in the United States who can practice medicine and surgery. Medical doctors, or MDs, which are the predominant physicians and surgeons out there. And then DOs, or doctors of osteopathic medicine, who are fully licensed to practice medicine surgery throughout the United States. The advantage of DOs is that they receive extra training in musculoskeletal and neurologic issues related to the body. And they approach care in a very different method. And this history is a very long and proud tradition that stemmed from the mid-1800s that's been proliferated throughout the United States. And the approach is that the body has an inherent ability to heal itself, and that other forces come into play which can aid the patient to get better and to improve. And the comprehensiveness of that approach is akin to the comprehensiveness of physical medicine and rehab, and additionally to the comprehensive approach of pain management, which is a really multimodal treatment paradigm that uses different strategies, which outside of the external strategies that a provider may give to the patient or share with the patient, it really depends on the patient's participation and willingness to get better and to understand the role that they play in the treatment.
Yeah, and that's huge. And I think that's something that, as in the PT world, we get to see patients much more often than you guys do. And we talk about fear avoidance and that sort of thing, and I'd love to dive into that. But just there's such a psychological component to low back pain, and the fear avoidance and things like that. So I'd love to have you touch on that a little bit later and how that affects outcomes, right? Because sometimes, and I've been through it myself, the first thing you do is you bend and twist and you're in excruciating pain and you can't move, or you start to get that referred pain and you say, oh my gosh, I just need to not do anything for 3 days to a week. And you and I both know that could be the worst thing that you could do potentially. So
Sean, sorry to interrupt. I'm having a hard time hearing you. If there's a way to increase your volume.
Here we go. Can you hear me okay now?
Still a little muted.
Hang on.
Can you all hear me?
I can hear you pretty well here. And if you guys want to just type into the chat box that you can hear us both, that'd be great. Perfect. Can you hear me okay?
I can hear you better now. Thank you.
Okay, good. Perfect. All right. So it looks like our audience.
And just to go back to your previous comment, the fear avoidance behavior that patients have is understandable, and a lot of it comes from their personal history with pain, and also their history of other issues like trauma. And pain is a very individualized and subjective feeling, and pain management, as well as rehab medicine and as well as rehabilitative medicine that you practice, takes into account all of these factors that influence somebody's loss of function.
Right. So let's use that as a diving board, and let's just dive right into, who is your ideal patient? Let's just kind of keep it to low back pain. Obviously, you see a bunch of different diagnoses. Who is somebody who you can really help?
So I think the ideal patient is a motivated patient who understands their injury, understands why it happened, and sometimes injuries aren't necessarily avoidable or completely understandable because the body is a complex machine. But the more successful patients have introspection about their own pain, their own experience with pain. These patients should understand self-care options, meaning preventive strategies that can be utilized moving forward, and also have some understanding of factors that may have influenced their pathway into pain. I also feel that it's very important that patients who achieve success in any type of treatment, whether it's acute treatment or longitudinal maintenance of treatment, have realistic expectations about what their recovery means to them. Meaning, say you have an elderly person whose intent is to be able to walk to the mailbox without pain or with less pain, and that really matters to them in their daily routine. That may be a different goal than, say, a younger person who's participating in sport and wants to get back to being a triathlon. So it's important that the patient understand the context of their own desire and what they want to achieve in order for them to be successful.
And for us to be successful, right? Because we don't know, we don't know what people are trying to get back to. It's the first question within the first 10 minutes, and I'm sure you have the same conversations. What function have you lost, or what do you? I always ask, what are you hoping to gain from physical therapy? And usually it's really question specific, right? So if you ask the right question, they'll tell you, I want to walk to the mailbox. I want to be able to play in the playoffs this year, for my soccer, whatever it is. But let's dive right into some of the non-specific low back pain that gets really kind of, mucky, right? So, just gets muddy and just nasty. So, let's talk about potentially maybe, we're talking about specific diagnoses, but like 50 to 55-year-old, degenerative disc, some stenosis. Let's dive right in and kind of talk about that patient.
Sean, I'm sorry if I may interrupt. I think the issue is on my end with my air conditioning. If I could just turn it off real quick. I'll be right back.
Yeah, sure.
Okay, I apologize to you and everybody else watching. So if my understanding of the question was the typical types of pain in a certain segment of population?
Yeah, so let's talk about, and I think, and let's more so the patients that I have the most difficulty, and I think PT in general has the most difficulty getting better, and this is usually without MRI, right? Because most patients come to us without an MRI until they've, failed PT or had a good outcome. We kind of work through a movement-based diagnosis, and we do our functional tests and things like that. But for those listening with low back pain and without a firm diagnosis from with an anatomical diagnosis from an MRI, that 50-year-old with just back pain, low back pain, how do you approach them? They come into your office to say, hey, listen, I got low back pain. It's been going on for 3 to 5 years. Mechanism might have been a bend and a twist, and it's been going on for 2 weeks or maybe 4, depending on how long it gets into, they take to get in to see you. Let's just dive right in. And when do you consider cortisone? When do you consider, other pain options? And where do you start? What's going through your brain with that patient?
Well, I think it's really important to stratify patients in terms of certain buckets, and that helps to delineate what the treatment options could be. And this really is impacted by an appropriate, targeted, individualized history and physical examination. So if a provider overlooks asking the question, that could be the answer to understanding what bucket they fall in, the treatment is often going to fail. So from my perspective, in general, there are 3 buckets of patients with spine-related pain. It's sort of the chronic, non-specific low back pain, meaning there was no inciting event. It's been chronic, indolent here and there, exacerbations every now and then, sometimes hard to identify. And often these are the patients that are most challenging to treat because these symptoms have been here and there and treated by various providers or practitioners somewhat inconsistently. The second bucket would be patients with low back pain associated with what we call radicular symptoms, leg symptoms, for instance, or radiculopathy, which just means that there's pressure being placed on a sensory or motor nerve that may cause tingling or weakness in the leg. And that would be a separate category, and those patients are approached differently. And finally, the third category are patients who don't fit into either of those buckets, whose pain may be related to something else. For instance, an infection, a spinal tumor, something which isn't as obvious, or which doesn't necessarily add up when you're doing a history and physical examination. So something else that can't be overlooked. So in approaching a patient with, in their mid-50s, if I understood the question, it's important to stratify even that patient. You can't assume that there is any particular bucket they fall in until you ask the questions. As we all age, the degenerative process or arthritic process really affects us in different ways. And I have patients who are in their mid-20s who have accelerated arthritic findings that would otherwise be seen in patients much older, in their 50s or even 80s. And alternatively, I have patients in their 80s whose spines look like they're people in their 50s. So again, that speaks to the need for individualized assessment, diagnostic strategies when appropriate, and coming up with a specific individualized plan of care.
That's great. And I would love for you to touch on just the correlations between the anatomy and pain, right? So, we know that, functional exam or not a functional exam, but an MRI might find herniated disc on 80% of folks who are 50 plus, or I don't know the statistics, you may know better, but not 80% of people 50 plus have low back pain. So can you just talk to people about what the anatomy really means and if a herniated disc is a normal thing and what they should expect?
So it's always helpful when the patient's subjective symptoms correlate with true anatomical findings, or what we call objective findings. But patients with acute, subacute, or even chronic pain often have findings that are not necessarily correlated with objective anatomical findings. Meaning, a patient with chronic nonspecific low back pain may have leg symptoms or perception of numbness or tingling or even weakness. And those wouldn't be expected based upon the physical examination, which may not show that statically, meaning when you do the exam right then and there, or should you go down the path of diagnostic studies, which are thought to be, quote, normal. So anatomy is key. For any provider of spine care, which includes physicians and advanced practice providers and rehabilitation specialists like yourself, it's critical that we understand the anatomy, especially the neuromusculoskeletal system. And it's really important to put those systems or those body regions into a bigger context, meaning, say you roll your ankle and you have an injury, and then over time you develop back pain. And that injury, initial injury, may have changed the way your body moves or your body mechanics. So if you don't correlate the initial injury, rolling your ankle or stubbing your toe or something that would affect your ability to bear weight, say on that foot, or maintain full range of motion, then you'll miss the fact that that could have been the initial source of somebody's back pain. And when you look at the body as a whole, things make more sense. And there's a concept that I like, it's called Tensegrity. And it essentially pertains to the interrelatedness of parts. And it's a very osteopathic-minded approach. It's a very rehabilitation-minded approach where you don't want to just look at the problem area. You really want to put it in context of the entire body. And that's where a very focused but comprehensive physical examination comes into play.
Yeah, that's great. And, when I think that medicine is becoming more like that, Alexios, people are starting to look more at the whole body instead of, doing the quick forward bend, backward bends, and they just like a quick rotation, a down and dirty eval. And really, I know most PTs coming out of school now at least do the gait assessments, and but it takes time for you to really get good at seeing anomalies and anominate rotations and things like that. And I think on our end, after you've done it for a while, you can you get good at it. But it all matters. If you're not lined up at the bottom or you got a leg length, it could throw off QL, it could throw off a bunch of different things, and really affect the low back over time.
And I think that's where the most successful treatment comes into place is communication between providers like yourself and like me, where we understand the different perspectives. We can educate each other and remind each other about the holistic management of these patients. And it speaks to some of the problems with a siloed approach, say, by somebody who's just looking at one specific issue and not looking at it, whether it be a musculoskeletal issue or even a lab value that should be seen within the context of the whole system. And again, that's why I think we work so well with our rehabilitative colleagues like yourself.
Yeah, no, that's great. So, let's say, there's plenty of patients that get better with PT for non-specific, even low back pain with radicular symptoms, herniated discs, spondylolistheses. Let's talk about options. Let's say I hit a wall, Alexios, at 6 to 8 weeks with a patient, right? And they're just sort of, they're 60, 70% better, but they're still in back pain. They've still got pain. And again, I'm thinking of, maybe 50, 60 years old, had probably a 10 to 20 year history of back pain. What are, and I'm going to send them back to you and I'm going to say, Alexios, what are our options? This patient is 60% better. They're moving better. Their range of motion's improved. Their strength is improved. I've done the dry needling. I've done all the instrument assisted soft tissue they can handle. We've tried, X, Y, and Z. What are their options in terms of that next step? And what should they be thinking? And what are you educating them in terms of what to expect for pain and things like that?
Great question. I think the answer is multifold. I think whenever you evaluate a patient, have a discussion with the patient about a plan of care, it's always important to remind the patient that we may not be able to cure your pain or improve your function back to how it was when you were much younger. And that my goal and our collective goal often is to manage the pain better or to manage the loss of function. But in terms of the spectrum of spine care, it's fortunate that we have a lot of evidence-based or research-driven treatment options now more than ever. When I was a kid, I remember patients having low back pain, and the treatment was bed rest. And now we both know that was never, nor will it ever be, a good option. So I think a patient, say, who sees their primary care with back pain and is sent to physical therapy, which I think is a very appropriate strategy, and doesn't get better, it's really important to send that patient or engage that patient or to get an opinion of a subspecialist or specialist or subspecialist in musculoskeletal medicine or pain management about other treatment options. And there really is a spectrum of treatment options ranging from non-surgical or what we call conservative treatment options all the way through more interventional and invasive surgical options. And from my perspective, it's always important to first understand the level of pain and the level of dysfunction and what the patient has been engaged in, meaning what has been tried and what hasn't been tried. For some patients who, say, go to the physical therapist or an occupational therapist for initial treatment, that's great. That's musculoskeletal care. That's education. That's prevention. But sometimes patients need other strategies like medications, like behavioral strategies, like interventional treatments, percutaneous injections. And the role of those is to really synergistically work with the rehabilitation paradigm to control pain better so that patients can further engage in continued PT or continued OT, or just to be able to participate in exercise at home. And there needs to be a collaborative interdisciplinary approach where, say a physical therapist says, okay, I've done everything I can do for now. Can you help me to control the pain or the symptoms so that we can re-engage the patient when they're better? And again, that speaks to the critical importance of open communication.
Yeah, I think that's just a great way to put it, Alexios. And I think that, having seen so much low back pain and how it's sort of sinusoidal and how people do over time, like 5 to 10 years even with chronic low back pain, there are going to be bouts that I just can't treat somebody. They're just too inflamed and they need to be medically managed. And, and I think it's important for our listeners to understand, like, that doesn't mean you're going to be on NSAIDs for the rest of your life, or you're going to be on gabapentin forever, or you're going to need, cortisone shots every 3 months until you die. I think it's really important to just look at a consult with a specialist like Alexios. And what's really cool about your specialty too, Alexios, and your background is that you do surgery as well. So you kind of have the full gamut of and your outcomes, right? So okay, this patient is going to do really well with surgery, or this patient won't. So let's talk about that a little bit. I know I'm kind of pumped.
If I may interject, you mentioned something very important, and it's in monitoring patients' outcomes. Because if there's an assumption that patients are getting better just by your intervention, then you will overlook patients who are actually not getting better or who are sometimes getting worse. So there are objective standardized outcome measures for low back pain, such as the Oswestry Disability Index score. And that's something that can be universally performed by therapists like yourself or medical providers, nurses, etc. And that is a great way to longitudinally monitor how they're doing. So if counterintuitively, the worst scores on the ODI or Oswestry Disability Index are higher. So say a patient has a score of 80 or 90. That means they're severely limited in their function. And the goal is to get that number down. So say you initially see a patient who has a score of 80, and your treatments are getting that number down, and you're feeling good, and you're able to share that information with the patient to really enable them and to reassure them that they're going in the right direction. And then for whatever reason, their scores start going back up. Well, that's a clue that there needs to be a reevaluation, reassessment, which includes a history. Like, did anything happen in the interim that your score would go up? And it could be something simple as, well, they did something in therapy that they were stretched too far, or they went beyond their limit of range of motion, or in between the time you saw them and this next time, they had an injury, whether it be physical or emotional. And again, if that's overlooked, then you won't necessarily be successful in treating the pain over time. So that was sort of an aside. I'm sorry, I forgot the initial question that you asked me.
No, and just to piggyback on that, so every patient here gets either a modified or a true Oswestry, and it's nice because they can see the objective change, right? So they'll see when they fill out in 4 weeks, oh, I can roll over in bed better, or I can go up and down stairs better, or my pain levels are less. Because the first three questions are you like, what are your pain levels 0 to 10, or at least the way we do them, and then are you satisfied with treatment? Do you feel like you're making progress towards your goals? So I think that people, when they see that and they recircle all their answers, it helps them kind of see where they are from where they were.
And if I may add to that, it speaks to the subjectivity of pain. So say you're doing, you're doing great collaborative work with the patient, and you see their function improving, and you're sharing that with the patient. They come in with a pain score of 10 out of 10, and then you ask them, okay, what's your pain now? And they say 9 out of 10. Well, again, that 1 point improvement may be substantial to that patient, or speak to the subjectivity of pain, which has so many other factors, cultural factors, education factors, etc. But if you're able to show them objectively, oh, well, okay, the pain has improved only minimally or moderately, but look how much your function has improved. And that's a good way to reassure and educate the patient that they're going in the right direction.
Right, absolutely. So I think that was an aside too. We were talking about surgical versus non-surgical approach. So specifically neurosurgically, and I know you do some work with the spinal stimulators. Talk a little bit about what different kind of spinal surgeries you do, and what you.
So if I may back up a little bit, so just to get back to the conservative care options, we use I call it multiple tools in the tool chest to help people avoid surgery. And from my perspective, unless there are specific symptoms that would suggest they need surgery right away, we always try to engage in the things that are least invasive, such as specific types of medications, the rehab, and really communicating with the rehab specialists, behavioral strategies, the complementary and alternative medicine strategies, yoga, chiropractic, acupuncture, massage, and the like. And then we use specific percutaneous procedures like epidural steroid injections or nerve blocks. And then if their pain is responding, but perhaps not as much as you'd like over time, we do a lot of advanced treatments. We do neuroablative techniques, which means applying electricity to the nervous system to essentially cauterize or ablate a nerve for nerve-related pain, which would improve their function. And then we march on to other things like peripheral nerve stimulation or spinal cord stimulation, which has several subtypes, which means directly applying electricity to the peripheral or central nervous system to control pain. And that works in different mechanisms, some of which are still unknown. But in general, spinal cord stimulation therapy or application of electricity to the dorsal columns, which is a specific area of the spinal tract. One of the mechanisms is this theory called the blanking on it. The gate control theory. I apologize. And it's essentially a reflex where the patient's nervous system is tricked into not feeling the same type of initial pain or nerve pain. And the patient instead feels an alternative sensation, meaning tingling in the areas where they're having pain. Or with newer technologies, the patient doesn't actually feel any of that original symptom and just feels better. And so we call those treatments to be, those are the newer treatment options that a patient can be engaged in. And those again depend on several electrical paradigms, including the intensity of the charge, the voltage, the directionality of the electricity, the pulse width, things like that. And those are beyond sort of a typical talk. Those therapies often include implantable generators or batteries that operate the system, although most recently there are newer systems for patients who are somewhat shy about having an implanted battery where external batteries can be used. Newer generations of these type of therapies have also targeted, say, chronic non-specific low back pain, which is not nerve related. And I've done extensive research on one of them in particular, where there is peripheral nerve stimulation of some of the muscles that are primary spine stabilizers, the multifidus muscle, to control chronic low back pain. Other sort of advanced treatment options include disc therapies, where electricity is applied to discs to actually help to treat disc-related pain. We also have a therapy called intrathecal drug delivery, where small amounts of very concentrated medications can be delivered into the spinal canal, avoiding taking a medication like morphine or OxyContin through the mouth, which has a lot of issues with it. There's been a big focus on opioid abuse over the last many years. And that affords the ability, that affords pain control that is more provider controlled to avoid long-term effects of addiction per se, and it creates a situation where there's a collaborative effort between the patient and the provider to really control the pain without having the bad side effects. So those are just some of the more advanced treatments that we do.
Yeah, I mean, I've obviously got a million questions, but I think to save time, let's just talk about. I really love this. And you're obviously targeting the sensory nerves, right? So whatever. When you're doing the nerve stimulation or the ablation, right? Or can you just dive into
the central and the peripheral nervous system. So we apply electricity directly to the spinal cord or to the nerves that come off the spinal cord, meaning the periphery. Other neurosurgical practices also apply electricity to the brain. So deep brain stimulation has also been used for chronic pain that is otherwise not responsive to some of the more conservative treatment options that we would do.
Can you talk about, do you ever combine some of that stimulation with like a laminectomy or a fusion or anything like that?
So the role of surgery is when there is a compressive, we'll say lesion or issue, meaning there is pressure being put on a nerve, causing numbness, tingling, weakness, or nerve pain that's out of control, that hasn't been responsive to more conservative things like injections combined with physical therapy or medications. So it's always important to try the least invasive approach possible. So newer treatments such as microdiscectomies, where a small amount of disc is taken out through a microscope to alleviate pressure on a nerve. The latest iteration of that is endoscopic spine discectomies, where an endoscope, like a tube that would be done to doing an appendectomy through a very small incision, now can be used in the spine to really limit the amount of cutting per se and really reduce recovery time. And other indications for surgery which are more invasive, say like a fusion, are more when there's instability of the spine, meaning that bones of the spine or vertebrae are misaligned, or they're moving, or if there's trauma, say a spinal cord injury where there is pressure being put on the nervous system, and in order to alleviate that pressure and extending the injury, there needs to be a fusion of bones to stabilize that area. And fusions per se can be done with instruments, meaning rods and screws, or they can be done without. And there's a lot of evidence that's showing that fusions generally help leg symptoms or radicular symptoms over back symptoms. And there's certainly concern that some of these surgeries may have been used in a way that patient selection wasn't the best, wasn't triaged appropriately. And some of these patients do poorly. And those are often patients that can be responsive to treatments like intrathecal drug delivery or spinal cord stimulation. So there's this continuum of care where we may try the most conservative approaches, and then the patient has a surgical approach, and they still don't recover. And we've tried all the least invasive treatment options, and then they would come back to have a spinal cord stimulator or a pump. And we're having a continuity of care in, say, one treatment location or one facility or center is really important, because then you can take care of the patient longitudinally and in an interdisciplinary fashion.
Right. I think that's huge. And I think in order to track your outcomes too, to know what actually works, you want to have that 5-year and 10-year stats. You know what's
exactly
how things look. Let's talk about, I think that's great. And, I'd love to, probably off of this call, pick your brain about, going in there and seeing kind of how some of the bad disc herniations look and how you can help, help people like that, or even if they have super, really bad stenosis and you're still stimulating. But we can talk about that off the call. But let's talk about that pain. A lot of times, in the physical therapy world, a lot of us can get the pain, the radicular symptoms to centralize over time, but there's still that lingering pain in Fortin's area, right? So kind of like and just for the audience that's unfamiliar with what that means, it's the pain kind of into the middle of your butt a little bit. And Alexios, if you could kind of talk about that a little bit, and what options people have for that. So it's not pain down your legs for the audience; it's just kind of pain into the butt a little bit. So if you could just dive into that, Alexios, and kind of talk about how that's a little bit different than a radicular pain and just pain that's centralized to the low back.
So it's important to understand that the spine the spine exists within a skeletal system. So there's two types of pain overall. There's axial pain, which is more related to central pain or back pain per se, and then there's radicular pain, which is leg pain or even arm pain. And it's not always the spine. So if patients have buttock pain or hip pain or groin pain or thigh pain, it doesn't mean that it's a pain caused by the spine. And that it's really important to identify, because say patients have a hip pain and they get hip injections over and over, or they have physical therapy focused on just the hip, or sometimes even have hip replacement surgeries, and the source all along was the back, or vice versa, then the patient will never improve. So, in getting back to your question, say buttock pain, focal areas of buttock pain, meaning pinpoint pain that you can press on, are often due to things like sacroiliac joint dysfunction or the piriformis muscle, or general myofascial pain. And those types of diagnoses often are in conjunction with something else musculoskeletal, or something being off. For instance, if your legs have a different lengths and your pelvis is tilted, then you will have forces that are unnatural or atypical placed on bodies like the sacroiliac joint. And again, with a very careful physical examination, those areas can be identified. The myofascial system in and of itself, which is the myofascia, is the connective tissue that overlies muscles and is below the skin, has incredible referral patterns that should be identified, because things like trigger point injections, which medical providers do, or dry needling, which therapists can do, can help address those in conjunction with therapy to really improve the patient's symptoms.
Yeah, and I think it's, it gets challenging when you get kind of into the nitty gritty, and we do, obviously we do thorough assessments here, and we'll fix all the innominate rotations. And for the audience listening, it's your body moves in 3D, right? So you can have in flares, out flares, you can have anterior and posterior rotations. It just gets complicated. You can have up slip, down slip. So it just, it can get really complicated. So finding somebody who lives near you, who knows what they're doing, is really crucial, to identify all of these different things that Alexios is talking about. So I think that's great. It's just, number one, does it come from the spine, right? And I think if we can do repeated motion to figure that out pretty quickly, but then just maybe pressing your PCP for that X-ray of the hip, X-ray of the spine on top of the hip. If they just want to look at your hip, you have hip pain, have them, just look at the low back a little bit too. And I know sometimes Alexios, it cuts off like L1, L2, L3, like you'll get L4, L5 in the hip. But, just depending on, what they order, it can, you're not always getting a full view of the spine A to P and then medial lateral, which we want, and especially if you're getting older too, we might want a little flexion extension x-ray of that too, to see if there's any instability.
And if I may, I know the focus here is on low back pain, but say a patient has mid back pain, and the focus is on the thoracic spine or the mid back itself. And oftentimes pain in the mid back is referred from the neck or the shoulder or, areas above that. If you don't look at the body as a whole, then you'll have a difficult time diagnosing the fact that it's not where the pain is. It's somewhere else.
Right. And that's, and for everybody listening, that's why it's so important to understand that, there's, I'm a big believer in the Barnes, in the fascial slings, and, everything is interconnected. And, that's why stretching is so important. And, just finding somebody local who knows what they're doing and you can get an assessment from is just huge. But so we're kind of running out of time a little bit here, Alexios, and I want the audience to, have a little chance to ask us some questions if they have any. But what is your, if you had one or two things to give, for advice for the listeners, what would you give if people, for those suffering with low back pain or sciatica?
Well, I think in general, it's important to understand that the body has an inherent ability to heal itself. And that resonates even with back pain, that most back pain syndromes get better over time, whether there's intervention or not. So often that means that education and reassurance may be the best thing to give to the patient. And that, I think the other factors that are important is that there needs to be a constant communication, collaboration, and partnership with the care team, so that it's bilateral, meaning it's not just the provider, it's not just the patient. There needs to be coordinated care, and that there is responsibility of the patient and the provider to manage together. And otherwise, if it's one-sided, the outcomes won't be as good.
Yeah, and I think it's important that, and this is where healthcare is starting to get better, and we're looking at things. But, if I know that I'm at a wall with a patient, I can call you up, or I could call somebody, and say, hey, listen, Alexios, this person needs a cortisone shot this week. Can you get it done? And that sort of thing is just, sometimes that can't wait, and they just need to get out of that 10 out of 10 pain and get into take the week off and get into a state mentally and physically and emotionally where they can start to move again.
Right.
That collaboration, that's just so important. So I totally agree. But how can patients find you, Alexios? How can they reach out to you if they have any questions?
So I work at the Neuroprint Spine Institute in Rhode Island and Providence at multiple locations. Patients are always welcome to call me. There's a central number, 401-444-3777. And whether they're evaluated by me or one of my partners, I think it's really important to go to a practice that has a full spectrum of options, meaning all the non-surgical options that we've talked about, conservative care, through the surgical options, through the rehabilitative paradigm, and where there's good open communication, not only between the providers treating their pain, but also with the family primary care physicians and the internists, because these patients may be engaged in spine treatment, but when they're discharged, if they sort of fall off the wagon and they need to be reminded, then the primary care can be involved and say, these are the things that you talked about. These are the things you should re-engage in, and let's continue to collaborate.
Yeah, no, I think and I think it's important for the listeners to understand too that low back pain is something that can be prevalent throughout your life. So if you just find somebody close and find a specialist and stay in touch with your PCP, have that yearly checkup. And I'm a big proponent of the yearly physical checkup too, with either a PT or
absolutely.
It's just huge. I think that's
and to that point, even though most back pain is due to an inherent musculoskeletal issue, sometimes back pain can be more serious, a tumor, an infection, and if you don't communicate and update your primary care physician, those things could be overlooked.
Right. You don't want to be written off as just having chronic low back pain. You want to be able to have a conversation and talk through some of the red flags that we would.
Right.
Anything else, Alexios, that I didn't touch on? Or
no, I'm happy to share my thoughts. If there are any comments or questions from the audience, I'm happy to share my email with you, and they can contact me directly. I think it's important for patients to understand that back pain will generally go away, and that it's no fault of their own where some people have chronic back pain, and that you really need to have a good communication with your care provider and a good rapport to make any progress.
Just waiting a second here or two if there's any questions, but yeah, thanks so much for your time today, Alexios. Really appreciate that.
Thanks for including me.
I think this has been wonderful, and I think we've learned a lot. And it's great to bring on an expert like you who can share their wealth of knowledge.
I agree.
Appreciate that. And if I get anything coming in, I'll forward it over to you, and maybe we can get back to that.
Perfect.
Thanks so much for your time, Alexios, for joining me, and we'll have
Take care.